As you're learning bones, you're going to see that there are many different shapes and sizes, but all of the 206 bones in the body fall into one of four categories based on their appearance. Long bones are longer than they are wide. They have an elongated cylindrical shaft that we call the diaphysis. So this is the diaphysis. At each end, we have an epiphysis here and epiphysis here. Now I want to take you back to your chapter 1 terminology. What was the term we used for closest to the point of attachment versus farther away from the point of attachment? I hear you thinking. Proximal, closest to the point of attachment. Distal, farther away from the point of attachment. So if you look right here at the femur, this is the proximal epiphysis, the end of the bone closest to the point of attachment. This is the distal epiphysis, farther away from the point of attachment. So this is the most common bone shape. We find long bones in our limbs, including the hands and the feet, the legs, the arms, the toes. So even the small bones of the fingers and toes are called long bones because they are longer than they are wide. Short bones, well, think of them as sort of boxy looking. So they're nearly about the same as far as height and width. So examples of these include the carpals, which are the bones in the wrist, the tarsals, the bones in the feet, and also we have some sesamoid bones, which could be a separate category because they're sort of shaped like a sesame seed. But of the four categories that really exist, we call those short bones. And this includes the patella, which is the kneecap. Flat bones, now when you think flat, I don't want you thinking like a tabletop or a 2x4. Flat bones, think of them as being squished and curved. So they're flat, thin surfaces that are slightly curved. So this is the frontal bone. This is what makes up the bony part of your forehead. It's a flat bone because it's squishy. Now, when I say squishy, I don't mean you can mash it. I mean it's squashed flat. So it's a flat bone that is slightly curved. So the flat bones form the roof of the skull. Your scapula is a flat bone, and so is the sternum. And then we have sort of the miscellaneous catch-all classification. Those are your irregular bones. They tend to be somewhat complex and they don't fit into any other category. So we have several of these if you look. Well, that one's not long. That's one of your vertebrae. It's not long. It's not flat. It's not short. So we're just going to throw it into the miscellaneous irregular bones. So your vertebrae, some of the bones in the skull, like the ethmoid, the sphenoid, the maxilla, and also the coxal bones, which make up your pelvic girdle, are all classified as irregular. So as I just mentioned when we looked at the humerus on the previous slide, the shaft of the bone is called the diaphysis. It is made of compact bone surrounding a hollow space called the medullary canal. This is filled with yellow marrow in adults, red marrow in children. The epiphyses are the ends of a long bone, so this would be, of course, the proximal epiphysis because this is where it would attach at the shoulder joint. This is the distal epiphysis. This is the part of the bone that would make the elbow joint. Now, each of these epiphyses are lined with articular cartilage. Remember, anything that says articular, articulate, that simply means joint, to come together. Okay, so a joint is where a bone meets another bone. So that articular cartilage is made of hyaline cartilage. Remember, that's the one that looks like frosted glass. So it helps to absorb shock and reduce friction as those bones are moving. The metaphysis, meta tends to refer to something in the middle. So this is where the bone widens out and helps to transfer weight between the epiphyses and the diaphysis. So here, if you look right here, this is the wide part. That's the metaphysis. That's the proximal metaphysis, the proximal metaphysis. And down here, the wide part, this is the distal metaphysis. Now, this is the location of something called the epiphyseal plate. So an epiphyseal plate still has cartilage there. Now, let me remind you, we start out with all of these bones being 100% made of cartilage. So until they get completely turned into bone, we still have some cartilage remaining. Now, right here you can see this little line. That is called the epiphyseal line. There's no more cartilage there. So when there's cartilage there, we call it the epiphyseal plate, and that bone can still grow. But once like this, it's all turned into bone, then it is an epiphyseal line. It has fully ossified, and that bone cannot grow in length. On the outside of bones, we have a tough outer covering called the periosteum. Remember, peri means around, and anytime you see OST, that is referring to bone. Even sometimes just os refers to bone. Now, the periosteum actually consists of 2 layers, and it covers everywhere of the bone that's not covered by that articulating cartilage that we have at the epiphyses. The outer fibrous layer is made of dense, irregular connective tissue, and it protects the bone from surrounding structures. In addition to that, it also anchors the blood vessels and nerves on the surface of the bone and provides a place for ligaments and tendons to attach. The inner cellular layer of the periosteum includes osteoprogenitor cells, osteoblast, and osteoclast. Now we're going to talk more about these cells in just a bit. The osteoprogenitor cells and the osteoblast are going to produce the layers of bone matrix, the hard part of the bone, and the periosteum is responsible for bone growth in width. Now remember, the epiphyseal plates allow growth to occur in the longitudinal direction, so the bone gets longer. Appositional growth, or growth in bone width, is when the bone gets thicker. The periosteum is also anchored to the bone by collagen fibers that we call perforating or Sharpie's fibers that run perpendicular to the diaphysis. In addition to the outer covering, the periosteum, we have the endosteum. Endo tells you inside. So the endosteum is a thin layer of connective tissue that also contains the cells, osteoprogenitors, osteoblast, osteoclast. It covers all of the internal surfaces of the medullary cavity. And just like the periosteum, it's active when the bone is growing, repairing, and remodeling. Short, flat, and irregular bones, well, obviously they're different from long bones, right? All you have to do is look at them. So there's no epiphyses, no diaphysis, no metaphysis, and no medullary cavity. The outer part is composed of compact bone covered by a periosteum. The inner part is composed entirely of spongy bone with no medullary cavity. Now, if you look at the image here, you can see 2 layers, outermost and innermost, made of compact bone covered by a periosteum. Now, the inner surface of spongy bone is made up of structures called trabeculae. Trabeculae means little bridge. So these are just little bony bridges from one place to another, leaving all the spaces within that are filled with bone marrow. The spongy bone of the skull is called diploe. That word simply means double. Bone marrow is a soft connective tissue found inside bones. We have red bone marrow and yellow marrow. Red marrow is also called hematopoietic tissue because that's where our red blood cells are made. It contains reticular connective tissue, developing blood cells, and fat cells. Remember, those are called adipocytes. Its primary function is to make blood. The locations of red marrow differ between children and adults. In children, there's more red marrow, so it's widely distributed throughout the bones. It's located in the spongy bone, of most of the bones of the body and inside the medullary cavity, where adults have yellow marrow. So the medullary cavity, of course, is that space found in the long bones. As children mature, there's a change so that most of the red marrow is going to become yellow marrow. So especially in the medullary cavities of the long bones and inside the epiphyses. So there's a decrease in the developing blood cells and an increase in the adipocytes. So this fatty looking substance is called yellow bone marrow. This results in adults having red marrow only in a few areas. So selected portions of the axial skeleton, excuse me, like the flat bones of the skull, the vertebrae, the ribs, the sternum, and the hip bones, the os coxa bones. Adults have red marrow in the proximal epiphyses, also of each humerus and femur. An interesting fact about this transition is a condition called anemia. Now, most people think anemia means low iron. Well, it's not. Anemia means low blood oxygen. But it's the iron on the hemoglobin that carries the oxygen. So if your iron's low, you can have one of the several types of anemia. Now remember, anemia does not mean low iron. Low iron leads to one type of anemia. You'll get that in AP too. Anyway, so if you have a severe case of anemia, this can trigger the conversion of some of that yellow marrow back to red marrow, because remember, the red marrow makes blood cells. And if you make more red blood cells, then you have more hemoglobin, which has got the iron component that binds oxygen, and bam, oxygen levels go back up. And you knew it was going to happen. I went ahead and covered this first part on the previous slide. So let's just take this bone marrow transplant section here. So red bone marrow can be transplanted into someone whose red bone marrow has been destroyed by chemotherapeutic drugs or radiation, or in the case of someone with leukemia, where the bone marrow is producing blood cells that don't do their normal function. So red marrow is most commonly going to be harvested from the coxal bones, the hip bones, or less commonly from the sternum. Then those harvested cells have to be injected into the recipient's blood, and they'll be transported by the blood to the normal locations for red marrow. Now, this has to be very carefully matched between the donor and the recipient. Just like if you were getting a blood transfusion, you have to match to make sure it's as close as possible to prevent the immune system from recognizing those cells as foreign and then destroying them. Therefore, the transplant would be a failure.